Hi, everyone. Thank you for listening. My name is Brett Bracco,
I'm Audrey Brigham.
Emmanuel Hanjar.
And I'm Rija Javed.
and our project is titled Opioid Prescribing Patterns by Dental Providers at UConn School of Dental Medicine. So, to give you a little bit of background about our project, among healthcare providers, dentists are the second most frequent prescribers of opioids. It has been found that NSAIDs combined with acetaminophen are just as effective for treating oral dental pain. Despite these findings, research has shown that dentists continue to prescribe opioids over NSAIDs more frequently and for longer than needed to control dental pain. It is our opinion that the lack of opioid guidelines, along with non-judicious opioid prescribing, has no doubt contributed to the U.S. opioid crisis. Although there is ample research that investigates opioid prescribing in a private practice setting, there is limited research that does so in an academic setting.
So for our research project, we had one primary objective, and that was to analyze opioid prescribing patterns and pain management practices by dental faculty and residents at the University of Connecticut School of Dental Medicine outpatient clinics. Moving on to our materials and methods, we conducted this research by using a retrospective axiom chart review of patients prescribed opioids at UConn School of Dental Medicine from the time of January 2015 to December of 2019. We analyzed electronic health records of approximately 4,000 patients during this time period to collect data for our project. For each prescription event, the following data was collected, such as patient demographics, the reason for the visit, indication of treatment, as well as the opioid given to each patient. We used Microsoft Excel as well as the UConn Statistical Consulting Services to generate descriptive statistics and perform statistical testing for each specialty and for the School of Dental Medicine as a whole.
Now, before we talk about results, I'd like to talk a little bit about MME or morphine milligram equivalent. So MME is a value assigned to opioids to represent their relative potencies relatively to morphine. So basically, morphine is used as a gold standard to compare opioids to each other and to morphine, using morphine as the standard. Now we can see here on the screen, this is the equation to convert opioids to morphine. And the way we do it is by using a conversion factor that I'm going to talk about in the next slide. Now, this little table here, as we can see, morphine is given a value of 1, simply because it is being compared to itself. See, tramadol is given a value of 0.1 and oxycodone given a value of 1.5. Higher conversion factor, more potency. I'd like to drive this home. I'd like to give a clinical scenario. Let's say someone is prescribed 30 milligrams of codeine twice a day. Now, to convert this to MME, we see here that it adds 30 milligrams a day twice. It adds up to being 60. Now, we multiply this number by the conversion factor for codeine, which is 0.15, and we end up with 9 MMEs per day. Now, the CDC does give guidelines for prescribing opioids, and these guidelines are given through MMEs. So basically, they say that clinicians should always prescribe at the lowest effective opioid dose. And for both chronic and acute pain, clinicians should reassess prescribing more than 50 MMEs a day and should really avoid prescribing more than 90 MMEs a day. As you would imagine, higher dose means a higher risk of misuse, overdose, and even death. And evidence does not show that higher dose reduces long-term pain. In terms of acute pain and frequency, 3 days or less should be sufficient, and more than 7 days of opioids is rarely needed.
And now to move on to the results of our study. The pie chart on the left shows the departmental distribution of opioid prescriptions at UConn. Not surprisingly, a vast majority of prescriptions came from AEGD, that's because AAGD sees by far the most patients at UConn, about 2/3 of total patients. It is also important to note that the percentage for oral surgery is likely an underestimate because we did not have access to oral surgery patients who were entered in EPIC. We only had access to patients entered in Axiom. This pie chart shows the distribution of prescribed opioids. A majority of opioids, more than half, were for acetaminophen codeine, which is one of the least potent opioids, which is correlated with a lower MME. And now to the fun stuff. This trend line shows the number of patients receiving opioids each year from 2015 to 2019. From 2015 to 2019, there was a 94% decrease in the amount of patients receiving opioids. This trend line shows the percentage of patients prescribed an opioid versus patients who solely received non-opioid analgesics for pain management. From 2015 to 2019, non-opioids became the sole first-line drug for pain management. This bar chart shows the percentage of patients prescribed a simultaneous opioid and non-opioid analgesic. From 2015 to 2019, the percentage of patients who received a combination of an opioid as well as a non-opioid prescription increased from 18 to 34%. And that's important because we found that opioid prescriptions had a significantly lower MME when the patient also received a non-opioid prescription. This bar graph shows the average amount of days that patients received opioids for from 2015 to 2019. From 2015 to 2019, the average amount of days decreased from about 4 days to 3 days, which is in alignment with the CDC's recommendation to prescribe opioids for 3 days or less. This table shows a breakdown of MME by year, by prescriber specialty, and by prescriber level. From 2015 to 2019, the average MME decreased from 20.3 to 17.9. Across year, prescriber specialty, and prescriber level, 99% of our opioid prescriptions had an MME below 50, which is in accordance to the CDC's recommendation. So we found a steep drop in opioid prescribing from 2015 to 2019. We also found that non-opioid analgesics have become the first-line drugs for dental pain management. We attribute this decrease in opioid prescribing to increased opioid education. For example, AAGD implemented an opioid educational curriculum from 2018 to 2019. We also attribute it to increased prescriber awareness, as well as more judicious opioid prescribing from our amazing UConn clinicians. Now to discuss some limitations of our study. One limitation was that we did not have access to patient notes for inactive patient records. We only had access to the notes for active patients. Another limitation was a small portion of patients had limited or absent visit notes on file. Another limitation was unclear prescription instructions. A small portion of patients' prescriptions had to be excluded from MME calculations because it was unclear how many times a day they were to take the opioid. And then lastly, we did not have access to records that were documented in EPIC. We only had access to records that were documented in Axiom.
So just briefly touching on some ongoing opioid-related efforts at the UConn School of Dental Medicine. Our PI, Dr. Chata, is currently in the process of adding some opioid-related tabs to the medical history on Axiom in hopes to enhance opioid prescribing practices. Some of these tabs include the opioid risk tool, which is basically to assess a patient's risk of misuse prior to prescribing them opioids. The MME calculator, which helps providers give the correct dosage of the opioid. A voluntary non-opioid directive, which alerts clinicians to when a patient does not want to be prescribed any opioids at all, as well as a pain medication agreement, which just ensures that patients have only one provider that's providing them with a prescription for opioids. And then lastly, the School of Dental Medicine has guidelines for acute pain management, which have been approved by the Clinical Affairs Committee and are to be shared with clinicians shortly.
So our results display a promising trend in opioid prescribing at UConn. Our providers are prescribing opioids less frequently. They are prescribing opioids in lower MMEs, and they are prescribing opioids for less amount of days. Clearly, our providers are exercising more prudence before prescribing opioids. We have made great strides, and our practices could be even further improved with better documentation of opioid prescription. Performing such retrospective chart reviews as we have done are important and should be an ongoing effort. And here are acknowledgements. Thank you.